So now we're going to have Dr. Brittany Lamb. Dr. Lamb and I met, I guess, probably about a year ago, and she's an emergency room physician. So she sees all the time the stresses that can happen when all of a sudden you have to make an emergency medical decision that you were not prepared for. She's full of a wealth of information. She has a blog, she has a free audio training, and she has a program called Make Your Plan with Dr. Lamb. And like I always say about caregiving, you need to have a plan. So welcome, doctor. How are you today?
Hi, Linda. I'm doing so good. How are you?
I'm joyful and grateful and glad to be here.
Yeah, me too. Thanks for having me.
Okay, take it away. The floor is
All
all
right.
yours.
Let me share my screen. Dun, 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 dun. Oh, I think I figured this out quicker.
You're not the only one. Don't feel bad.
Okay. Can you see it?
Yeah.
Okay. All right. So today I'm going to talk with you all about how to avoid the top 3 mistakes when you're making medical decisions on behalf of your person living with dementia. Okay, so I'm going to cover quite a bit of material, and then if folks want to ask questions in the chat, I'll do my very best at the end to kind of answer questions. And Linda, if you see something that you want to interrupt
Yeah.
me and ask about, go for it. Okay.
Okay.
Okay, so my name is Brittany Lamb. I'm an ER doctor. I've been practicing since 2014 exclusively in the emergency department. And sometimes people ask me why I've gotten into the space of educating and helping dementia families. And really, it's because I see the stress and struggle that people go through in the moment. And crisis decision making is just, it's much, much harder to do. And I personally care about my patients that they get the type of care that they would choose if they were able to speak for themselves. I feel most physicians and nurse practitioners and PAs, we all want this, but the healthcare system is making it much harder to deliver these days. And so I think that you all just need a lot more access to education and information that you can consume on your own time. And so instead of complaining about what I was seeing and being frustrated by it, I decided to create my own small business and try to help people with this. So as Linda mentioned, I do a lot of stuff online, but I for free, but I do also have a paid course that people can go through if they want to really take control over their role as their
Yeah.
person's medical decision maker. Okay, so I did want to say today before I get started that nothing that I say can replace the boots on the ground people, the experts who can help you with your individual situation. And so this is not medical, legal, or financial advice. And I also want you all to realize I'm not here on behalf of any person or organization or any hospital system. This is what I teach my clients. These are the things I talk about and teach my patients. And so this is just me coming to you from my experience and my lens of seeing the world.
And we are very grateful for that.
Thanks, Linda. I did want to also mention that, and for anyone who's watching this in the future, this thing that I've put together for you all who are watching this training should still exist. So at the end of this talk, I'm going to be sharing a link for you to go to get a written guide for free of this entire presentation, the why and some of the meaning behind it. Because like I said, I think it's hard sometimes when you're learning new concepts in the moment to really remember them, and you want to be able to consume information in different sources and different modes. And so I'm here teaching you this live, but I've also written down quite a bit of information for you in a guide. So I'm going to share the link that you can go to access it and download it at the end of this.
Thank you.
Yes. So when I meet people in the emergency department, or I talk with clients who are their person's decision maker, they usually tell me things like, I feel like the medical team isn't listening to me. I'm not sure how to approach my person's doctor. I feel very rushed. I see a lot of people who are making medical decisions as a group, and they really struggle to get on the same page and be prepared and speaking the same language. I see a lot of people who are overwhelmed by information, and they want to do what's best for their person. They just don't know what's best, and they don't know what questions to ask. So people are feeling overwhelmed and stressed, and I recognize that. So I put together this training for people who are, no matter if you're making your person's medical decisions alone or you're doing this with other people, if you're really wanting to get on the same page and you're not really sure how this information in this training is going to be able to help you do some of that. And then for people who are doing this alone or in a group, if you're somebody who just, you want at the end of the day to know that you made the best decision that day for your person, and you don't want to live with second guessing and regretting your decisions, the information in this training is going to help you set up a foundation for how to start that process of getting there. And then I also want people to know, like, if you just want to know, these are the things that you need to go and do, well, that's what we're going to cover. As a decision maker, these are the things that you want to go and make sure that you've done. Okay, and then I wanted to just briefly mention the healthcare system. And it's so frustrating to work inside of. I cannot imagine being a caregiver and advocate for someone living with dementia, and having to navigate the system the way that it is right now. I've been a caregiver to both of my parents at different times. My father has passed away. He had brain cancer. And they're not living with dementia. They weren't living with dementia. I can't imagine how much harder it would be. The system is not really set up to support you all, and I think you all know that. There's definitely a lack of time that we have to provide you with education and information in the sessions and the meetings and visits that we do have. And then something else is that we don't talk about what's important to people as individuals soon enough. We wait too long to have discussions. And so it creates a lot of opportunity for people to receive too little care or too much care. So for most of us, our goals as we live are to continue to live and also to live with good quality of life. And what happens is the healthcare system is designed and set up to do things to people to keep them alive, and to keep them alive so that we can figure out whether or not they're going to regain their quality of life as they potentially recover from medical problems. When people are living with conditions that affect their quality of life and their values are different of that, sometimes we create this imbalance between the go, do of the healthcare system and what's actually best for the person. And it can set people up to receive too much care or too little care for them as an individual. It's a huge problem. And this is one of the things that I work towards online, is educating and empowering you all so that you can recognize when things are too much or too little. And this is the thing, is that you all know your person best. There's this gap in our knowledge and your knowledge. As a medical professionals, we know everything about the medical problem. We can help you see into the future and how things may affect your person, but you know your person better than we do. You know them best, right? And so there's this disconnect between what you're looking for and what we're looking for. And so unfortunately, I think it's going to take a lot longer to create longer visits with healthcare professionals, to create more teams and people outside of doctors' visits to help you all. And so my way right now of helping people with the system that we're currently operating in is to provide people with education and information so that they can go to the doctors and go to the professionals that they need with the right information, the right questions to ask, so that you guys can, unfortunately, some of the burden is still falling on you, right? A lot of it is, but so that you know what to ask for and you can better advocate. So we can try to close this gap a little bit. When you all are asking for things and, quite frankly, demanding change over and over and over again, that's how we make change in the healthcare system. So I'm trying to empower you all with information and ways to see things differently. So today we're going to talk about the 3 mistakes that you want to avoid when you're making medical decisions on behalf of your person living with dementia. I want you to have practical steps so you can take action. I want to save you from unnecessary stress. And I want you to focus your time and energy on what's important, and that is in protecting your quality of life and your person's quality of life, okay? When you know some of this stuff about what's coming and things that you need to be prepared for, you can stop worrying about them and you can spend your mental energy on other things. So let's go ahead and dive into the mistakes. So the first mistake that I see people falling into, and I just want to say also that the system has created you all to be set up to make these mistakes. There's no blame on you. You're not doing anything wrong. This is what's naturally happening to people because of the system in which we operate in. So the first thing that I see people doing a lot is over relying on paperwork. They say things like, we have all the papers in place, everything is covered. We have the advance directive. We went to the lawyer and we got all the papers drafted. My person has an advance directive doctor to me, my person has an advance directive and they also have a do not resuscitate form. So like, what else do I need? I don't need anything else. And it couldn't be farther from the truth. And this is something that I don't think we talk about enough because we do want people to create advanced directives, but I want you to realize what they are, what they do, and what they don't do. And I cover this in quite a bit more detail inside of the written guide that I'm going to share with you, the link that you can grab it at the end of this. So please remember this. If you remember nothing else, this is one of the key points from my talk today, is that any document you have that helps you know what decisions your person may or may not want you to make is a tool, but it's not a plan. It's not going to cover everything. There's going to be a ton of stuff that's not included. It is 100% a mistake to over rely on this paperwork and thinking that it's going to help you make all medical decisions. So I'm going to briefly talk about the types of documents that we use as tools, but not a plan, because you're going to see these documents, you're going to hear these terms, and I want you to have some clarity around this. So let's first talk about the legal documents. So I call them legal documents because a lot of times they are approved by the state, by the legislature. They're approved documents that are considered legal documents. You can fill them out on your own. You don't need an attorney to do this, but a lot of people get these documents filled out when they're doing a will or they're doing a trust, they're doing estate planning. They usually are not filled out with a medical professional. So a doctor usually, they take them from you, they put them on file and they should read them. But most of the time, these are not crafted for you individually with your doctor, which I hope that this kind of changes over time, but that's a topic for a different day. So we call these legal documents advance directives. And that means, quite simply, right, they're supposed to direct your healthcare wishes in advance of you not being able to talk about them or speak about them. There are two main purposes behind advance directives. One is to name who you want to make your medical decisions when you're no longer able to speak for yourself, when you need someone to step in and speak for you. And those are called different things in different states. So one of the most common terms is medical power of attorney, but you may also see terms like healthcare proxy, healthcare power of attorney, healthcare surrogate, healthcare directive. No, that's different. Healthcare agent is another term. So like surrogate, proxy, agent, there's all different names for the same idea. It's just who is going to speak for this person on their behalf when they're no longer able to and make their medical decisions. And then there's another type of directive that's kind of come out of this, and it's what kind of care would someone want or not want. And this talks more about treatment and preferences towards care. And usually these documents, that's what's their intention and their purpose is to give us an idea and information about what a person would want. And so examples of those, the most common is a living will. The 5 wishes is a newer document that's being used. And 5 wishes also includes, as one of the wishes, who you want to speak on your behalf. So there are some advanced directive documents that combine both of these things. So their purpose is to tell us who's supposed to speak for you, and then also what kind of care preferences do you or do you not have, okay? And these documents you must do for yourself. So the person living with dementia has to be able to understand what these documents do and don't do and be able to sign them and engage in a type of conversation in order to be able to sign these and make these legal documents, which means when they've lost that ability to do this, you can't do these documents on their behalf. Okay, so that's kind of an overview of the legal documents. And that, like I said, there's a little bit more information about logistics and some terms and things that you need to know inside of the guide I'll share with you in a little bit. On the other side, there's medical forms that can help you as tools for making medical decisions on behalf of your person. And these are called medical order forms. And when you do these with a medical professional, so in most states, it's going to be a doctor, so a physician like me, a nurse practitioner, or a physician assistant. And there's really only a handful of these documents. There's the do not resuscitate document, which tells us that someone would not want to have CPR if they are actively dying. They don't have a pulse in their wrist, their neck, their groin, and they're not breathing. Okay. Then there's do not intubate forms, which tell us that someone would not want to be on a ventilator at any point. And then the third type of document is called a pulsed or a MOLST form. Okay. And let me just give you a little bit of history on this. So this is a medical order form that came out of Oregon in the 90s. And basically what they said was, okay, well, if people have preferences towards their care other than CPR, like how are we to know that? How are we to document that in a form that medical professionals can follow? Because once you have one of these forms on file, it goes with you wherever you live. So it goes wherever the person living with dementia lives. And medical professionals are supposed to follow this form when it's applicable and relevant to the person's situation. And paramedics, 911 first responders, and nurses, they're not responsible for reading advanced directives like a living will and 5 wishes and interpreting them and acting upon them. That's the job of a physician, or a nurse practitioner or physician assistant, like inside of the hospital or a living facility. So these people in Oregon said, well, gosh, we need a document that helps us when someone is not actively dying, but is sick and needs medical care. And so that's where PULSE comes from. And it's a national program that's spread all over the country. And so in different states, there's different names for this document. In Maryland, they use the term MOLST. In West Virginia, I believe it's still POST. I live in Virginia and we used to use POST, but we've adopted the national PULSE form. And it used to stand for Physician Orders for Life-Sustaining Treatment, which is where the letters come from. But now PULSE is just a term that the national program wants us to use as a term. So the document talks about CPR, but then it also talks about, okay, if somebody's sick, do they want every medical intervention available to them? Do they want some things, but not all things? Or do they want more comfort-focused care? And those preferences are documented and checked on this order form, and then they can be acted upon by medical professionals taking care of them later on. So it's a very helpful document, but they have limitations. So all of these documents are tools. They're not a plan for your person, not a complete plan. Okay, a lot of information there.
Somebody just asked, so this PULSE form or whatever,
Yeah.
you do that through your doctor?
Yeah, so these are signed by medical professionals. And the do not resuscitate has been around for a while. Everybody knows about the do not resuscitate. The PULSE form is newer. Okay, so it started in the mid-90s, and so not every doctor is going to know about it. So you might actually have to, like I was saying, bridge the gap. You may actually have to educate your person's doctor. And I will also say that not every state has widespread use of the form either. So there are some states that you can't implement PULSE. It is still in your best interest to have read the form, because these are some of the medical decisions that you're going to be asked to make as your person's medical decision maker. So even though you can't actually create the document in your state, you can still know what you would do in those situations. You can still have a conversation about these treatments. Yeah. So, but it's a good tool for those who have it, and most states have a program. Okay. So the first action step that I want you all to take is just go find the paperwork that you have. Figure out who is supposed to make medical decisions. If that's been named, if a person's been named, read the advanced directive, like the living will or the 5 wishes, so you can see what it covers and doesn't cover. Okay. And if you have medical order forms, please read those. Okay. And realize that, and that's something I didn't mention just now, you can, as a medical decision maker, either named on paper or because you have a legal right to make your person's medical decisions, like you're the only family member, or you're their spouse, or you're their child, and you have a right to do this, you can fill out the medical order form with the doctor on behalf of your person. Unlike an advanced directive, you can't do that for them, but a medical order form you can. So if your person doesn't have a medical order form and you think they're appropriate for it, that's something you need to talk to their doctor about. But you want to read these documents, okay? And if your person still has the ability to make their own decisions, you want to make sure that their advanced directive is as custom tailored to them as you can. And then also that they've named a medical decision maker on paper, because it's much easier when there's someone named in a document. And then to help you help your person receive the care that they would want. So I just wanted to briefly talk about some medical decisions that are not covered in these documents. So things like which doctors your person's going to go and see. Like, are they going to continue to go see the neurologist? Are they going to keep going to see the cardiologist, the kidney doctor? If it would and go in line with their goals and wishes, when would they want to start hospice care and go see that team? Palliative care is something that everybody should have access to. That's not going to be mentioned in these documents. When to start medications, when to stop medications, extremely important medical decisions, not going to be included in these documents. The power to do this on behalf of your person is going to be mentioned in the document, but not like the actual decision and giving you guidance on it. And you're going to have to make these choices, whether or not your person's going to have surgery, what kind of tests they're going to have, like blood work and imaging studies. If they get sick, they need care, whether or not they're going to stay in the hospital. If they come to the emergency department and they see a doctor like me and we say, I think maybe we should put them in the hospital, that decision and whether or not it's worth the risk and it's going to be beneficial to them, those decisions are going to fall to you. And what their overall goals of care are, which is something else I'm going to talk a bit more about in a minute. And also I dive a bit deeper into this inside of the guide that I put together for you all. It tells us how much care someone would want if they value quality of life, especially. So these are things that are not covered. So you just need to realize that there's things that you're going to have to decide about, because most people living with dementia live for years, and some people living with Alzheimer's live for decades. And so it's not about end of life. And that's what a lot of these documents are focused on. They're focused on decisions made at end of life and when someone's really, really sick. And there's a lot that goes into it before that you all are going to have to decide upon. So realize that there are holes in the documents. Realize that they're tools, not a plan. If you avoid this mistake, you're going to already be much better off than a lot of other people. And just keep in mind that your decisions are going to affect where your person lives, what type of care they need, what their life is like on a day-to-day, their quality of life, and how long they live even too. So it's important. And then mistake number 2, so moving on, is forgetting about like taking a step back and looking at the big picture. I think that when a lot of people, when we're involved in the caregiving role, we get so focused on putting out fires and having to handle day to day that sometimes it does help us to take a step back and just zoom out a little bit. You know, there's a lot of decisions that you all have to make. There's a lot of stress and emotions. And this is just one part. Being a medical decision maker is just one part of your role as advocating and caring for your person. So it's important to keep your finger on the pulse of the big picture. So let's talk a little bit more about this. When we make decisions in our lives, we make a lot of really big decisions, which is why I know that you are all completely capable of this, because I do this with people in the emergency department when they're under a ton of stress. So my whole goal and mission is to help people think about decisions that they're going to have to make ahead of that. But when we make big decisions like where we're going to live, what job we're going to take, if we're going to quit our job, when we're going to retire, where we're going to go on vacation, even if we're going to buy a new car, you know, if we're going to remodel our house or sell our house, there's all these big life decisions that we have to make as we live. And I think most of us, we want to gather information and apply that information to our situation and have time to think and process. And that's just a little bit harder when we're making medical decisions. Some of that can be done, but there is one key thing that if you keep your finger on the pulse and you think big picture, there's one thing that will help you every time you're asked to make medical decisions. And that is knowing your person's values of quality of life. And so what I find is most of my patients, most of them, not all of them, but most of my patients do value quality of life. They care about how they live on a day-to-day. There are some people that do not. There are some people that want to live and that's their primary goal, and they're okay with living with worse quality of life. They're okay with having their life prolonged and not living with what everybody else would judge maybe to be good quality of life. It is there's an individual value for each of us between how long we live and how our quality of life is while we live. So it's important to know what your person's value is of quality of life. And then if they do value quality of life, then we have to dig a bit deeper and actually figure out, well, what does that mean to them as a person, as an individual? Like, what gives them meaning and purpose and joy, and what makes it worth being alive? Like these are the things that we need to know, because it will help us, it will help guide us in medical decision making. Okay. And I want to tell you a story about a family that I took care of a few years ago, actually, before I came online to do this work. And it was a woman who was living in her, I think she was in her late 80s or early 90s, living with dementia, probably like middle stages of disease. She's still walking and eating, and she's still having conversations with her family. But she was brought into the emergency department by car. So they came in. They signed in for high blood pressure. And I was working in a freestanding emergency department, which is an ER that's not physically attached to a hospital. And it wasn't that busy. So I was actually able to go in there pretty quickly before they started doing a bunch of stuff, because for people living with dementia, I tend to try whenever I can to get in faster to avoid repeating histories and doing things that may be more distressing to the patient that are like our hospital protocols. Not always possible, but anyway, I went in there and I could tell that she was very anxious. And I'd explained to her family, her blood pressure is high, but it's probably high because she's uncomfortable. She's anxious. They told me in medical settings, this is kind of what she does. And so she had a history of urinary tract infections, and she'd been acting a bit differently. And sure enough, she had another urinary tract infection, but they signed in for high blood pressure. And when people come to the emergency department for high blood pressure, really you can do a little better, you can do a lot, because I'll tell you all that usually when you're having an emergency related to blood pressure, you are going to come into the ER because you're having symptoms that you would come in for completely separate to your blood pressure. And so typically, a lot of times people come into the emergency department for high blood pressure, and there's very little that actually needs to be done. But for a person living with dementia, they have a harder time communicating how they're feeling and their symptoms. So I offered this family testing, like blood tests, blood work that we could do. So looking at the kidneys, looking at the heart, sometimes we even do CT scans of the brain to look for bleeding when someone can't give us a history. But I didn't suspect any of that, but I offered it because that's part of my job. And they weren't sure how to make the decision. So I asked the question, well, how would she judge the way she's been living the past few weeks to months? And they said, oh, well, she wouldn't want to be alive anymore. Her daughter straight up said that to me. She wouldn't want to even be alive anymore. And I was like, oh, really? Tell me more about that. And she said, well, we had conversations. She said when she couldn't have meaningful conversations and interactions, couldn't follow what people were saying, couldn't engage, when she couldn't advocate for herself, when she couldn't read books. That was one of the things that has stuck with me ever since I met this family, that she said when her mom couldn't read books anymore, that was one of the things that she wouldn't want her life prolonged any longer. So I said, well, if we did do blood work and we found an issue with her kidneys or her heart, would she want to be in the hospital? And they said, well, no, because she wouldn't even want to be alive. And so I said, okay, well then you signed in for high blood pressure. She has a urinary tract infection. Let's treat her urinary tract infection, treat her discomfort, relieve her anxiety from feeling this way. Her blood pressure got a bit better just by the environment, not because we started her antibiotics. And they went home and we talked about other things that they needed to work on as far as her medications, and talking to palliative care and talking with the doctor about her overall goals. But that family was able to make all of her medical decisions that day, and also to think about the future, because they knew about what her values of quality of life were. They had kind of forgotten that, and no one had said that to them. No one had prompted them to think that way. So it completely changed the trajectory of their care. And there were all these other things her daughter was then going to go and do because of the interaction that we had. So it's important. And it really does. Like, you remember these types of conversations and these decisions that you make much more than documents, really. Conversations are the most important thing. Some people living with dementia are not going to be able to engage in conversations about what quality of life means to them anymore. But that doesn't mean that you can't do this on their behalf. So these things need to be discussed with you, with the rest of your family that's helping you make decisions. talk to your person's friends, talk to the people that have known them the longest, do some digging and try to figure out if they care about quality of life, what does it actually mean to them? Start writing this stuff down, okay? And this will help you know what their goals of care are. So full treatment is, I'm going to just briefly talk about this, but it's in the guide I'll share with you all. You know, some people have good, what they judge to be good quality of life. People can live with wonderful quality of life who are living with dementia. Okay. So they may want every medical treatment available to them. All right. That's full treatment. People who value quality of life may say, well, if the medical condition is likely to be able to be treated and I'm going to be able to live with similar quality of life, then I may, in some situations, want more aggressive medical care than in others. It depends. It matters to me whether or not I'm going to recover and whether or not I'm going to recover with similar quality of life. Those are some, but not all people. They want some medical care, but not all. It just depends on the situation. And then there are people who would already judge their quality of life to not be what they would want, like this woman that I took care of in the emergency department. So her treatment should always be focused first on providing comfort. And that doesn't mean no care. It doesn't mean that you can't have pain medications, that you can't come to the hospital for injuries, that you can't have surgery. If the intention behind the care is to provide comfort first, then we are meeting the goals of care of that person. So people's value of quality of life directly translates into their overall goals. And if you can say to a doctor, you know, these things, if you can simplify, like, yes, we want everything done that's available because they're living with good quality of life. We want some things, but not all things, or we want the care focused on comfort. That helps us direct you with treatments, like what lines up with that, depending on the situation that you're in. So just keep in mind that goals of care and quality of life are important. So, and let's move on to mistake number 3. Okay. And that is that I want you all to realize that medicine, there's patterns in medicine. What's happened to someone in the past is more likely to happen to them in the future. What happens to people as they age, as they're living with diseases like chronic illnesses, like a disease causing dementia, issues with the heart, what happens as those things go forward in time? We know what happens to people. We can foresee the medical complications that people will have based on their age and their medical history. So I want you to realize that it's potential. There is a potential, and you can look to your person's future and start thinking about what types of decisions you might be having to make on their behalf. So you can start thinking about what's appropriate for them now. And then if their goals of care would change over time, what would be appropriate for them in the future? People not realizing that they can plan ahead is another mistake to avoid. And so when we talk about what someone's risk is, because it's all individualized, okay? So we can tell you what your person is at risk for. Your person's doctor can have this conversation with you, but your person's past medical history is the biggest thing that drives this, okay? So whatever medical problems they've had in the past, whatever they're being treated for now, it helps us know what might happen to them in the future, because medical problems like high blood pressure, diabetes, high cholesterol, somebody who's smoked, like these things all put you at risk for having issues with your blood vessels, which means you're at higher risk of diabetes and stroke and heart disease and kidney disease. And so we can help you plan for that. Okay. So your person's personal medical history is extremely important. It's one of the 3 big key players in determining their risk. They're also someone who's aging. It doesn't matter how old your person is. Your person can be in their 40s. There are even some people that are being diagnosed with early onset dementia in their 30s and 40s, okay? And so every one of us is aging. So as we age, we're at risk of more medical problems. Some of the things I've already mentioned, like stroke, infections, falling with different injuries. There are things in heart disease, things we're just at risk for because we're aging humans. And then because your person is living with dementia, they're also at risk of certain medical problems, okay? And you can learn about those. And there are things that you've already heard about: trouble swallowing, trouble walking, difficulty controlling your bowel and bladder, incontinence issues, infections, okay? And a lot of the conditions that people are at risk for are more towards the later stages of disease. So, but these are all the things that go into determining what is likely to happen to somebody in the future, the things that you're likely going to have to make decisions about. So what I want you to take action on is the first step of this. And the first step in determining your person's risk is by looking at their individual medical history. So I want you to gather your person's medical history. And this is something that people fight me on. This is something that I hear all the time. People are like, it's in the computer, doctor. It's all in the computer. And I just want you all to remember that the information that's in the computer is entered by humans that make mistakes and that it's not always updated. I've seen so many inaccuracies in the computer. It's also the information gets buried in there because there's so much data to get through. Okay. So the exercise of you gathering your person's medical history has benefits to you. Okay. And that is, I had a client recently that told me that by the exercise that I have people go through in my program, where I have them gather their person's medical history, she said it was like a weight had come off of her because she realized that she couldn't prevent all of these things from happening to her person, that things were likely going to happen. And it made her realize that she can do everything she can as an advocate, but that it's not within her power to stop all medical problems from happening to her person, and so that was a big thing. I think that also when you understand your person's medical history, you can have better conversations. So when you're talking to medical professionals, instead of them having to explain to you like the conditions that your person has in the limited time, they can actually talk about what's best for your person based on their history in that moment. And I can tell you specifically as an emergency medicine doctor, I love when people hand me medication lists. And I love when people hand me like a couple page documents of bullet points or a list of their person's medical problems, because it allows me to focus my attention on them and not having to look at the computer. And usually when people ask me to look at the computer, I actually have to leave the room because I have to be available as the ER doctor to nurses, to other doctors calling me on the phone, to a patient that's coming in with a stroke or a heart attack, or an ambulance, a paramedic that's calling to get advice about what to do for a patient in the field. I can't deep dive into your person's medical history in the chart in their room. So I have to leave you physically. And so being in your presence allows me to talk to you about, well, this is what your person looks like. This is the story you're telling me. These are their vital signs. This is their risk. Let's talk about what tests we're going to do, whether or not we think they're going to stay in the hospital right now. So you can ask me questions. Ultimately, when you do this work of gathering your person's medical history, it helps you see into the future, and it will help you make sure that you're choosing care that lines up with what your person would want. So it's super, super important. And so I want you to organize it however it makes sense to you. Clients have sent me spreadsheets. They've sent me tables that they've created. They've sent me Word documents. As part of what I do for some of my clients is they send me their person's medical history, and I analyze it for them on video, and I send it back to them, telling them the things that they need to pay attention to, medications, questions to ask. And I've seen them come to me in all different forms. So I ask them to give me certain information, but they give it to me in all these different formats, and that's fine. But when you're actually going to look for your person's medical history so that you can gather it, I want you to do 3 things. Okay. So the first thing is I want you to find their medications. Anything that they are prescribed, anything that they are putting into their body, make a list of it. Okay. If you don't know what it's for, figure out what it's for. It's really important that you know the purpose of all the medications that your person is taking, right? And this also goes for you too. Like you should know the medications, what the purpose is of them that you're putting into your body. If you don't know what the medication is for, just Google the medication. If you still can't figure it out, then ask a pharmacist or ask your person's doctor. And I want to tell you all that medications are a huge reason why people come into the emergency department. People have all types of issues from medications alone. And so every medication your person takes needs to have a purpose. It needs to be beneficial to them. It needs to be worth the potential risk. And it needs its own plan because it should go in line with their goals of care. Is it protecting quality of life? Is it prolonging life? Is it providing comfort? Is it lining up with what your person's goals are? Giving medications because someone's been on them for forever is not reasonable. And oftentimes what I find is people get put on medications to treat the symptoms of other medications. There's a huge push right now for deprescribing medications, taking away medications to see if people get better. There's a huge problem with polypharmacy, which just means that people are on more medications than they should be. I can't tell you how many ER visits I see because of misuse of medications, because people aren't provided enough education about them. Each medication needs should have a purpose, and it should have a plan for what we're going to do with it. And I'll just say real quick, if your person is on blood pressure medications and they're not eating and drinking like they should, this is one of the most common things that I see happening to people. They get dehydrated and they're still taking their blood pressure medications because they didn't know that they should not take them, and you didn't know that you should hold them potentially, like check their blood pressure and see what it is before you give it. And then their blood pressure goes lower, which means they get less blood flow to their kidneys. And then their kidneys get irritated, and then they have trouble breaking down the medication. So the medication builds up in their system and causes side effects. It's extremely common, and it's preventable if people just had access to this information. So I'm a stickler on meds because I worry about people just taking them and not understanding why they're taking them.
Yeah.
Thanks, Linda.
Yeah, that one really gets me.
It's so annoying, and I feel so bad for people. So when I do analysis of people, I tell them, like, watch out for these medications if they're vomiting or having diarrhea, because people you get a cold, you get sick. Okay. And then, so the first step in gathering your person's medical history is finding the meds. And then the second thing is reading doctor's notes. And this used to be harder because we used to have them all. You used to have to request medical records in order to get notes. But there is a law, and I can't remember the name of it, but basically now people have access to their medical records. And you can even see your ER doctor's notes. Like, you can see all of our notes now. You may have to do some, you may have to do a little bit of investigative work to get access. And it is easier if your person's medical decision maker on paper, but I know you all can figure this out. But it's important to understand your person's medical history in order to think about their future. So you want to read the notes for the person's primary care doctor, because it will give you a general overview of their medical problems. We want to include surgeries on there. Okay, and usually the primary care doctor will have that on there, but don't forget about surgeries. And then you also want to read the notes for any specialist that your person is going to. So if they go to a lung doctor, kidney doctor, nephrologist, cardiologist, the heart doctor, because these doctors they own that organ, that system, right? And so they will write way more detailed information about your person's medical problems, which could be very helpful to you. The staging of them, how severe they are, what they're thinking about looking for in the future, and maintenance of them. So important to read those notes and include that information that you're gathering in their medical history. And then the last thing one of the other places that you can go to find medical history that's relevant is discharge summaries from the hospital. Now, when people come into the hospital, when they get discharged, there's a doctor typically, or a nurse practitioner, physician assistant, that will write a summary about what happened in the hospital, what treatment was done, what testing was done, and what medications the person's supposed to be discharged with. Anytime someone's hospitalized, it could happen again. In medicine, history repeats itself in medicine just like it does in world history, okay, and in human history. So if it's happened before, it can happen again. Even stuff like coming into the hospital to have your gallbladder out or your appendix removed. Now, of course, you're not going to regrow your gallbladder and need to have it out, or regrow your appendix. That's not going to happen. But you are at risk of having complications of like bowel obstructions, blockages in the intestines, because you've had surgery in your belly. So any medical hospitalization is relevant information, and it potentially could happen again, okay? Or could set you up for some other medical problem. So it's important to include. Okay, so those are the things that I really want you all to work on, okay? So action step number 1 is that we're not going to fall into the mistake of over-relying on paperwork. We're going to read the papers, and we're going to find the holes. We're going to look at the advanced directives. We're going to look at any medical order forms and realize that they're tools, they're not a plan. Then I really want you to discuss what quality of life means to your person. Do they value it? And then what does it mean to them? What does it actually mean? Write down the things that give them quality of life. And then action step number 3 is gathering and organizing your person's medical history in a way that makes sense to you so that you're better able to communicate with medical professionals and you can start planning for your person's future and the decisions that you're likely going to have to make on their behalf. And I wanted to address this because I find a lot of people get very stressed out and overwhelmed when I start talking about these things, and that's normal. If you've never heard this stuff before, I can understand why it would be like, wow, that's a lot of stuff I need to do. Just keep in mind that this is not a sprint, it's a marathon. Okay, you do not need to go out and do all of these things in one day, but these are things that you must do if you want peace of mind and you want to be a confident medical decision maker. They're really not negotiable. Like, if you want to have peace of mind and you want to feel good about the decisions that you have to make, you need to do these things. Okay, but it's not a sprint, it's a marathon. It's over time. And also, I find that it's heavy. It's not like, this isn't lighthearted stuff. Thinking about a person that you love and you care about no longer being able to make these decisions for themselves and having to step in and do this work, it doesn't feel great. Okay, that's normal. Okay, there's nothing wrong with you. That's normal. And I just want you all to know that there are resources out there to help you with this, and that when you do this work, it will benefit you in the long run. So again, it's a marathon. When you avoid these mistakes, you're going to avoid overwhelm and indecision and second guessing yourself, because it's going to help set you up to have a plan for how you're going to act in advance. Mm-hmm. If you're doing this work alongside your family, which you need to, if there's more than one medical decision maker, it's going to potentially protect relationships that you have with your family. It's a big deal. You can go to sleep at night knowing that you made the best decision on behalf of your person because you showed up and did everything that you could on their behalf. And the stuff when we do this work, the stuff that we learn and uncover, it's not just for our person, it's also for you. It's for you in your own life and communicating your own goals and wishes. And then also, when you're asked to step in and advocate for somebody else, a friend or a family member, you're going to be better able to do so. You guys have this power. This is in your control, and you're 100% capable of taking control over the disease and this part of the role of being someone's caregiver advocate as the medical decision maker. You can do this. I know you are, because I know you're capable, because you all make hard decisions all the time. Every single day, we have to deal with stuff in our lives that is not easy. I do think that people benefit from having a roadmap and resources. I think that overall, when you follow a process, you save time, and it takes away some of the overwhelm and stress. Okay. And so that's what I've come online to do. And so I want you all to connect with me. And if you've benefited from this training, I want you to go to this website. So it's my website, blambmd.com/3 mistakes. You just put in your first name and your email address, and then it will deliver to you a downloadable guide that goes along with this training. And full disclosure, when you sign up for this, you'll be added to my email list. And I typically email people every Friday, some sort of helpful resource or a blog I've written or a video that I've made for them. I do sometimes email more when I have a training event or something that I'm trying to let people know about, but typically it's weekly, and you can unsubscribe at any time. If you don't like what I do, you just unsubscribe. So there's no pressure. I just want to help you all. And then I'll just leave this slide up. You can scan this QR code. It should take you right to the page. And then I'm happy to answer questions.
2 questions that have come up. One is, What is 5 wishes?
Yeah, so 5 wishes is an advanced healthcare directive. And you can fill it out. You don't need an attorney to fill it out. And it has 5 wishes about what you want your care to look like. And I'm not going to lie to you, I can't remember them all off the top of my head, but I know one of them is who you want to speak on your behalf. And one of them is like, how comfortable do you want to be? Like, do you want to, like, how much does not being in pain matter to you? And again, it's more geared towards end of life. That document is, it can be very helpful though, because there's space for you to fill out the answers to the questions in writing in this packet. And you can go to 5wishes.org, I believe it is, to get a copy of it. I think I think it's $15.
Okay.
And they also have, I have this in my desk. They have a guide, like a conversation guide,
Okay.
for families. So they have a lot of really good resources on their website. I do recommend it. Oh, wait,
Okay.
here, I have the wishes. I'll read them to you. Wish number one, the person I want to make healthcare decisions for me when I can't make them for myself. Wish number two, what my wish for the kind of medical treatment I want or don't want. Um, and it talks about life support treatments and end of life experiences you've had in those situations. That information you can fill out there. Wish number three is my wish for how comfortable I want to be. And then this is it's talking about end of life. My wish number four, my wish for how I want people to treat me. And so, that's more about like dignity and respect and what that means to you as a person. And then wish number five is my wish for what I want my loved ones and healthcare team to know. And it's like, what's most important to you, for communication and what good care means to you. So I think that it can be very helpful, but it is geared towards end of life. So again, it doesn't cover all decisions.
Right, but it still starts conversations too that maybe haven't been had before, which I think is important.
Yes.
Someone else sent in a message and she said, my mother wants to put in her papers that if she gets seriously ill, she's going to stop eating and no one can force her to eat. Is that ridiculous or what? That's what she said.
Yeah. So if a person naturally stops eating on their own, I will say as a doctor, a lot of times that can mean that they are reaching the end stage of a disease. That's
Right.
common in the end stages of cancer. It's common in the end stages of dementia, end stages of COPD, congestive heart failure. Now, I will say also that sometimes people stop eating when they're depressed. And so that's something else that we would want to think about. But I do think that force feeding or hand feeding a person who's living with dementia at the end stages, it is prolonging their life. And if they are naturally not eating and not having the desire to eat, that is a natural part of the dying process of moving towards end of life. And so that is not an unreasonable thing to write in a directive.
Okay. It was very interesting. I recently went to my 51st high school reunion, and a woman came up to me and she said, I heard you speak one day and it changed my whole experience. She said, my husband had stopped eating. She said, and I thought, he's going to die if he stops eating. And she said, you said to me, no, he's not eating because he is dying.
Yeah.
So,
yeah, it's hard to talk about. I think that because most of us, when we don't eat, we don't feel good. We feel awful. We're hungry. We're starving. Like we get all those cues from our bodies, but that's because our bodies are working and our brains are working. And when a body is reaching end of life, it's natural for it not to have a desire, the person not to have those cues and those desires. So they're not suffering, like you're not starving to death. It's just
someone else asked a question and they said, aren't there some states now where there is assisted death?
yes, there is physician assisted suicide in several states, and not physician assisted suicide. Not what is it actually called? Is it physician assisted suicide? But there are states that do that. I can't name the states, but I think the problem specifically there's issues with it with depression, and there's also issues with it with people living with dementia, because in order to have a physician assisted death, you do have to have capacity. And this is something that I teach inside of this guide I'm sharing with you all. I talk about capacity versus competency and the terms that you need to know. But if you don't have capacity to make your own decisions, if you can't understand what it is that's happening, you can't consent to physician assisted death. Yeah. So for dementia, for someone who's lost capacity, they wouldn't be able to do that.
Okay. I think that's all we have for right now.
Okay. Well, I'm happy to, if you all sign up to grab the guide, then people can email me. So when you get emails from me, you can email me questions, and I answer all the emails that I get. So
thank you so much, my friend. I so appreciate you. This was a great presentation, and we'll talk soon.
Okay, sounds good. Thanks, Linda.
Have a delicious day.
All right, you too. Bye.
Bye-bye.